you so much for joining me this morning. This is a little different, presenting from my home through teletherapy or telehealth style, but I am really excited to present to you guys today about interoception and its role across settings. I currently am an occupational therapist working for Providence, contracted as a school-based occupational therapist in the Beaverton School District. So I work with mostly kindergarten through high school age students. And previously I worked for Providence in the Newburgh region, and I got a great opportunity to dive into a lot of different settings that way. I worked in the outpatient pediatric clinic, but then also did neuro patients. You know, I'd see a kid at 10 o'clock and then a person who had had a stroke at 11 o'clock, and then on Saturday I'd work in the hospital. And of course they didn't have enough OT needs at the time to work 40 hours a week, so I got to jump up to St. Vincent's one day a week too for the first 3 years of being an occupational therapist. So I do have history working in both the schools, outpatient peds, neuro, and in acute settings. And I really do want to acknowledge that you guys are all occupational therapists coming in from different settings. And I think that this could be a great topic to share with you today. If you have any questions during this, feel free to put it in the chat. You know, I appreciate that you guys kind of showed your face a little bit, so I don't feel like I'm just talking to a brick wall. And I really do appreciate you guys being here and taking the time out of your weekend to come join me today. Just a little bit about where this all kind of came from for me. Last summer, I went to the 2 specialty conferences through the American Occupational Therapy Association. The first one I went to was in Orlando, and it was the pediatric or children's and youth specialty conference. And at that conference, I got the opportunity to listen to Amy Lynch, who is a professor at Temple University, and she does a lot of work around trauma, kids who have experienced trauma, and she's doing a lot of research in that area. And she also worked with Kelly Mahler to present about interoception. And Kelly Mahler has been an occupational therapist who's really made waves in the field of interoception and linking that new, growing concept. It's not new, it's been around for a long time, but growing that concept into a way for occupational therapists to provide treatment strategies to help people who struggle with interoception. And I came home from that conference and I was just like, I had so many aha moments and felt like things really came together with my understanding of how the whole sensory processing system works and how interoception is really connected to our emotions and how we feel. And I felt like I really came away with a lot of tools and resources that I wanted to bring to not only my clients, but also share with, the professionals around me, including the teachers I work with and paraeducators. And I see this as a huge opportunity for occupational therapists. I also went to a conference, the specialty conference in Chicago last September, and that was regarding mental health. And Amy Lynch there talked for a whole day-long seminar about trauma. And then I also went and took some courses from Temple University through her, and I've been really feeling a lot more confident in, my awareness of how the brain works and the body connection. And I think there's a lot of great opportunities for us here. Let's see. I just wanted to touch base that, for example, the interoception field is really booming within neuroscience right now. Like for an example, in the year 2005, there was roughly 50 publications that year that were put out that included topics of interoception. But in 2015, there were over 350 research publications. So it really is a growing field in the neuroscience area. And, I think part of it is they're really being able to use functional MRIs and doing tests where they can really look at those deep parts of our brain and see what they're actually doing. So let's get started. There we go. Oh, I gotta share my screen. Let's. Hold on one second. Sorry for the. I'm doing like a double screen here, so I need to be able to see my notes. Okay, can you guys see my presentation?
Yes.
Okay, so we've got a lot of graphics going on here, and yeah, I want to just kind of share with you like of this man is really depicting, you know, a lot of emotions, and he's obviously feeling really strong feelings, and his body is giving him signals and he's connecting them to emotions. And all these pictures will elicit some kind of response from you. I'm thinking, you know, the cute dogs in the corner, those are actually my dogs on a hiking trip this summer. And, you know, that might elicit in you a feeling of, ooh, cute dog, warm, friendly, cozy. Or, you know, if you're not a dog person, that might elicit a, oh, I'm not really a dog person kind of feeling, you know. Or like when the wildfires were coming close to Portland, I actually felt within my body kind of my fight or flight nervous system reaction of like, man, do I need to flee the area? And I, you know, felt like my whole body was feeling like I was in some kind of fast forward mode, or I felt, you know, like maybe this is what ADHD feels like, because I am, you know, on cleaning out my garage or doing something that doesn't need to be a stressful event. I was trying to get ready for teletherapy, so I was trying to get all my therapy supplies in order that weekend for being a school-based OT. And, you know, it wasn't something that needed to be a stressful event, but I was feeling stressed and feeling like I had to do things really fast, or and I, you know, could see my emotions just getting kind of all over the place. And, you know, I live in Beaverton, like the fires weren't really an impending fear to me, but as I was watching the news stories and things, I did feel that my nervous system was reacting. And I needed to, you know, calm myself down or just notice those feelings and connect them to how I can regulate myself. And that really in and of itself is interoception. I was noticing those feelings within my body. And then I was telling myself, okay, it's okay. Yes, the fires, they're in the area and this is a really scary event, but right now my body is safe and I don't need to do anything but keep my body calm. That's the best, but it is that protective response that your body is, and mammals and maybe even birds and different animals do have that reaction to, you know, flee when situations arise. And that comes from our sense of interoception. And yeah, that snake over there, you know, it's all connected to like our instincts. And that is definitely something that would rile my sister up like no other. But when I see a snake, it doesn't really have that same effect on me. And maybe it's because of some, you know, historical event that happened in her childhood where she got this sense of fear from snakes because, you know, it startled her and it caused that reaction. Okay, so let's go to the next slide. Let's talk about the nervous system. And I know we're all OTs and we all have studied the nervous system in the past, but I think it really is a big thing to come back to. And so just talking about the nervous system, it does play a role in nearly every aspect of our health and well-being. It guides everyday activities such as waking up, and automatic activities such as breathing, and complex processes such as thinking, reading, remembering, and feeling emotions. Within the spinal tract, 80% of the signals that are going either up or down are actually going up. We're receiving input from all different organs in our body, and it is sending information to our brain, and our brain is then trying to figure out what to do with that information. And only 20% of the information of the messages are descending back down to our body, where our brain is telling us to, you know, move your feet a little bit or pick up that glass and take a drink. So that really, there's like tons and tons of signals that are traveling up to our brain, giving us information from our various body parts. And the nervous system controls a lot. It controls brain growth and development. It controls our sensations, and it controls our perceptions of those sensations. So the mental process of interpreting the sensory information. It controls thoughts and emotions, learning and memory, movement, balance, and coordination. It controls sleep and stress and the body's response to stress. It also controls aging, breathing and heartbeat, body temperature, hunger, thirst, digestion, puberty, reproductive health, and fertility. And neuroscientists study these and other nervous system functions in both healthy and disease states. And studying and understanding the nervous system is really important because it does affect so many areas of human health and well-being. Okay, so I know, peds therapist, I'm going to tell you a little bit about sensory processing, but don't worry, it's not all going to be directly related to pediatrics, I promise. So we, in kindergarten, we learn our 5 senses: taste, sight, hearing, touch, and smell. And these are often considered external senses. So, seeing / vision integrates all of the senses, especially our vestibular and proprioceptive sets. So seeing orients us in our environment and helps us interact with the environment. Seeing provides us with protective skills and can be key to survival. If we want to see that cougar when we're on a hike to make sure that we know how to react appropriate. Then there's the smelling, olfactory, and that's directly linked to the limbic system for emotional connection and survival. Then there's taste / gustatory, and that's not about nutrition. It's what tastes good to us and how we react to it. And eating can be used for self-regulation. A lot of times people eat because it feels good and we like what we enjoy. Then there's also the hearing / auditory system, which helps us to locate where sound is coming from. It helps us to screen out noises that aren't important, but pay attention to the ones that are. It helps us with communication, and it integrates within the body, within the vestibular system. And things like music and rhythm can be regulating. It regulates our heartbeat, respiration, and it can provide a calming effect, or it can be alerting. A different kind of music might be more alerting. And it can definitely change your mood and your emotion. And then, of course, there's touch and tactile, and that's the largest sensory system. We have receptors all over our body, receiving tons of input all the time. It's one of the first senses to develop in utero. And we need to be able to reach out and touch things to understand the world as we're developing. And we have to be able to tolerate to touch and learn and feel, and also to interact with others. And then we get into more of the hidden senses. So these senses of vestibular, proprioception, and the 8th sensory sense, they call the most hidden sense, as interoception. So vestibular is our movement, and the receptors are in our inner ears. When you move, it kicks in. It lets you know where you are in space and how your head is in relation to gravity. And it interrelates in the ears and eyes for input. It's a major organizer for all systems and input, and it lasts a long time. And it's also important for posture, balance, and equilibrium. Then there's the proprioceptive system, which is our body sense receptors in our muscles and joints, and it lets us know where our body is and what it is doing. And our brain is hungry for input about what the body is doing and what movement is going on. And we need a good proprioceptive system to be able to move about and explore the world. And it can be regulating and calming as well. It can be really regulating, actually. So now we get into interoception. So Dr. Bed Craig in 2002 is really kind of the most, he has done a lot of studies to really show what interoception is. So he's kind of like the grandfather of interoception, even though, yes, they were talking about it back in the 1790s. But he's been able to do some recent studies that really have given us way more information. And he describes interoception as the job of our interoception sense is to enable us to feel the inside of our body. So this graphic here is showing that we can feel a lot of different ways in various parts of our body. You know, I mean, just going in there, we can feel pounding, pressure, prickly, pulsing, queasy, squishy, squirmy, stabbing, stingy, stretchy. So our body is able to notice all these different senses and differentiate them in different body parts. Interoception allows us to feel internal sensations coming from many areas of our body, and clearly helps us to identify exactly how we feel. So the interoceptive system helps us feel many important sensations, including pain, body temperature, itch, sexual arousal, hunger, thirst, heart rate. If we can feel our breathing rates, muscle tension, pleasant touch, sleepiness, and when we need to go to the bathroom. Interoception helps us sense a variety of general and localized feelings such as warmth or coldness, tickling or shivering, tension or relaxation, constriction or expansion, sinking or lifting, trembling or steadiness. And, you know, all together, our sensory systems work together. But I think it's especially important to consider the interoceptive sense. But all together, the senses help us to learn about the world around us. They help keep us safe and calm. They regulate our alert, calm level for best functioning. And they help us attach and have social connections. They also help us to communicate to others how our sensory system is working. So interoceptive awareness can broadly be described as like the conscious perception of internal bodily cues. So it's like our awareness of our heartbeat, our awareness of breathing. And it is related to emotional experiences, both of which are affected in individuals on the autism spectrum scale. And poor interoceptive awareness is linked to many conditions we'll get into in a moment. So notably, interoception is a key component of our emotional experiences. Interoception, or the awareness of our internal body states, is the basis for how we feel emotions. For example, you know, before a public speaking event like this, you might feel your heartbeat increase, muscles tense, you know, fluttery stomach, and a slight overall shakiness. I know I feel those even today as I'm talking to a screen here. But you know, based on how you feel these, then you are able to connect it to what we typically think of as emotions, like nervousness. So interoception sense gives us a huge mind-body connection. It gives us the ability to notice those body signals, like our heart beating fast and our fluttery stomach. And then it gives us the ability to connect the body signals. So interoceptive awareness ultimately is the ability to notice the body signals and to connect them to an emotion like nervousness. So it is the sensory system that gives us the most information regarding our body emotion connections. So interoception and the brain. So they have found that the insula is the interoception part of our brain. And the insula is deep within that lateral sulci in the parietal lobe. It's really deep within the brain. So the area of the brain that receives the most information regarding our interoception is called the insular cortex, or the insula for short. So the insula uses this information sent through the nervous system from areas such as the heart, bladder, stomach, and it translates the incoming signals into a message that we can identify on a conscious level. For example, the insula might translate these signals into a body state such as hunger, thirst, sexual arousal, pain, coldness, etc. Or it might also give us an emotional state like fear, anger, happiness, excitement. In either case, the insula processes the interoceptive signals and allows us to be more aware of how we're feeling. So in the end, ultimately, the insula is the part of the brain that allows us to answer the question, how do I feel? So yeah, getting back to the history of interoception, it was mentioned as, or not interoception of it, the insula. The insula was mentioned as early as 1796 by German physician Johann Christian Riehl. However, because most experts thought it had no major functions, no one paid much attention about it to that area of the brain. And due to its deep and hidden location in the insula, deep within the lateral side of the brain, it was difficult to study and continued to be misunderstood. It wasn't until modern advanced brain imaging technology was developed that we're now able to really look deeper into the brain and study the deep structures of it. I think that also comes into play with how and why there's so many more studies in psychological research that is talking about interoception. And I think that is a huge area where occupational therapists really could and should jump on board. I mean, this is a huge connection between an area that occupational therapists really have a lot of knowledge in terms of sensory processing. And, you know, I think it plays for a great role in an interdisciplinary area to work with these psychologists and provide therapy, sharing both of our combined knowledge of the brain and sensory processing. So yeah, like functional MRIs have allowed us to see what areas of the brain are lighting up in different individuals and to compare them. Okay, so really what we're talking about is, you know, interoception is huge in terms of the brain and body connection. And it really does go back to evolution. One piece that I think is really important to talk about is late in Darwin's career, he published the book called The Expression of the Emotions in Man and Animals in 1872. And that book is an exploration of the foundations of emotional life, filled with observations and anecdotes drawn from decades of inquiry, as well as like his experiences with his own children and his own pets. So Darwin starts by noticing the physical organization is common to all mammals, including human beings. We all have lungs, kidneys, brains, digestive organs, and sexual organs that sustain and continue life. And he proclaims that man and the higher animals also have instincts in common. And I think a lot of this goes to like our higher level metacognition in our brain. So we all have the same senses of intuition, sensation, passions, affections, and emotions, even the more complex ones like jealousy, suspicion, gratitude. I know I noticed some of those in my dog. And I actually happen to have two dogs, and one of them's name is Darwin. So I thought, oh, that's a funny little connection there. And humans share some similar physical signs of emotion too. Like, you know, the hair on the back of your neck might be standing up, or you might, you know, grit your teeth when you're angry or frustrated. And that kind of can be compared to how, you know, dogs show their teeth when they're enraged, and can only be understood as part of our evolutionary process. Darwin proposes that mammalian emotions are fundamentally rooted in biology, and they're an indispensable source of motivation to initiate actions. So I think that's huge. Like, our emotions are rooted in biology, and I think that it's huge to think about, like, that's the indispensable source of motivation to initiate actions. So reading this, I immediately connected it to our theories in occupational therapy, specifically from the model of human occupation. And the MOHO explains how occupations are motivated and organized into daily life patterns and performed within a person's environment. I like to think of MOHO as a way to organize and understand how to use occupations into practice to improve people's health by understanding how and why meaningful activities are motivated and patterned and performed, and we repeat them. So within this definition of MOHO, there are like 3 key terms. And one is volition, which is that motivation piece, habituation, so our habits, roles, patterns, and then performance of our occupations or daily activities. So furthermore, one more thing about MOHO is that it is based on an open systems in interactions with the environment. While humans interact with their environment through occupations, and we receive input and output. So it's almost like MOHO's really tying in the nervous system without even realizing it, or maybe Gary Kielhofner was just putting it all together and I'm just realizing where all the pieces come into play. So yeah, I think really it is a big evolutionary process, and there is huge connections within the brain and body that we're just coming into awareness of. So this really can be huge when people have a difficulty with poor interoceptive awareness. It is linked to an array of conditions. It's linked to anxiety, depression, sensory processing disorder, ADHD, eating disorders, both anorexia and overeating and bulimia. It's related to schizophrenia, dementia, OCD, PTSD, panic disorders are a huge relation, suicide attempts and planners, drug and alcohol addictions, and chronic pain syndrome. So one term that you might see if you go into researching more about interoception is the term alexithymia. And alexithymia is a broad term that originally in Greek terms, it was loosely translated to like, you have no words for the emotion. So it's like you can't put how you're feeling into words. So in other words, it's poor interoceptive awareness. And it's estimated that 1 in 10 people has alexithymia or poor interoceptive awareness. So in other words, alexithymia is poor interoceptive awareness, and it's a term for people who have impairments of interoception. So this function of interoception is increasingly recognized as an important component of different mental health conditions, including anxiety disorders, mood disorders, eating disorders, addictive disorders, somatic disorders. And one thing I did want to mention here is that in 2016, the Laureate Institute for Brain Research organized the first Interoception Summit. And that was a gathering of interoception experts and scientists from around the world. And they met with the goal of accelerating the progress in understanding the role of interoception in mental health. So the discussions were organized into 4 themes: interoceptive assessment, interoceptive integration, interoceptive psychopathology, and and they created a generational, like a roadmap that could serve as a guide for further research. And I wanted to mention that because this interoceptive summit is actually on YouTube. So you can look it up if you're interested. And it is, a lot of neuroscientists using a lot of big words. And, I think it's a really great way to learn more about interoception, but some of them are kind of cold, not cold, but a little bit bland at times too. But it's a great way to learn more about interoception and the scientific research. And like I said, there's hundreds and hundreds of papers out there on interoception. I have a pile that's about 500 pages of different research articles that I've downloaded and dived into in the last year. Okay, so initially when I signed up to present this course today, I didn't necessarily plan to really go into trauma and trauma-informed care, but with it being 2020 and with all that's happened in the world and in people's lives, I think it's really an important time to really make sure that people are talking about trauma and being more aware of how that is connected to both interoception and our overall mental health and well-being. So, what is trauma? Trauma is, if you look it up on Google, there you go. It's a deeply distressing or disturbing experience. It could also be a physical injury. So, trauma is abuse, neglect, household dysfunction, divorce happens, discrimination, community violence, medical stress, school problems, disasters, poverty, pandemics. So they also talk about within trauma-informed care, like the 3 events. There's the event, there's the experience and how the person processes all of that, and then there's the effect. Let's see, and so trauma-informed care is an approach that assumes that an individual is more likely than not to have a history of trauma. Trauma-informed care recognizes the presence of trauma symptoms and acknowledges the role trauma may play in an individual's life. And on an organizational or systemic level, trauma-informed care, it changes the organizational culture and emphasizes respecting and appropriately responding to the effects of trauma at all levels. It's similar to the change in the general protocol of like universal precautions. Within trauma-informed care, practice and awareness becomes almost second nature and pervasive in all service responses. So trauma-informed care requires the system to make a paradigm shift. It's shifting from asking, what is wrong with this person, to what has happened, what life experiences has happened to this person. And the intention of trauma-informed care is not to treat symptoms or issues related to sexual, physical, or emotional abuse or any other type of trauma, but rather to provide supportive services in a way that can be accessible and appropriate to those who have experienced trauma. So when the service system's operating procedures do not use a trauma-informed approach, the possibility for triggering or exacerbating trauma symptoms, and it can re-traumatize individuals, and that can increase. So touching base, in case you haven't heard about it, or just to review, back in the 1990s, there was a study done by Kaiser Permanente that was a really large study, and they looked at how adverse childhood events affect people and their further on other diagnoses. So you can see within this tree, there's adverse childhood experiences like maternal depression, divorce, incarceration, domestic violence, and then you can also see, the person is rooted. And so the roots down on the bottom play a lot of part into our environment. Poverty, discrimination, poor housing, violence, these are all things that can be adverse childhood effects and affect our reaction to them. And also a big, huge thing is that they found that an individual's resiliency can kind of negate the adverse childhood experiences effects. So if you have a really great foundation with loving parents and a nice home environment where you feel safe and secure, that can help have resiliency against when adverse childhood experiences occur. Like currently right now, we're experiencing the pandemic and kids aren't even in schools, but the kids that are gonna be able to be most resilient and bounce back are the ones who have the most stable structure and home and have food in their bellies and that kind of thing. So adverse childhood effects are development and the reactions we have. And 90% of people with a mental health diagnosis have experienced trauma. That's huge. It definitely shows a connection. And over 2/3 of children report one or more trauma by age 16. And I'm taking a big guess that this number is rapidly increasing in 2020. So ACEs are common. About 61% of adults surveyed across 25 states reported that they had experienced at least one type of ACE. Nearly 1 in 6 reported experiencing more than 4 adverse childhood events. And preventing adverse childhood events could potentially reduce a large number of health conditions, from things like depression and heart disease. So, and some children are at greater risk than others. Women and several racial ethnic groups, minority groups, were at greater risk for experiencing 4 or more types of ACEs. And these ACEs are costly. The economic and societal cost to families, communities, and society totals hundreds of billions of dollars each year. So here we are, 2020. Everybody has experienced huge disruptions in life due to COVID-19, rioting. There's a lot of positive outcomes with the Black Lives Matter, but it's also having big event effects within rioting and whatnot. There's enormous wildfires and whatever else is going on in life. Kids can't even go to school right now, and I'm being a virtual therapist right now. So, yeah, ACE scores are dramatically being affected by the world we live in. I think 2020 couldn't be over sooner. And I wanted to discuss too another scientist who really was an early giant and major contributor to psychology and trauma specifically, and that was Ivan Pavlov. So yeah, the bell ringing was used as a trained conditional stimuli that made the dogs in his study salivate in anticipation of the food associated with the bell. And losing such autonomic trained associations between the bell and the food is known as extinction. So this is a cornerstone actually of cognitive behavioral treatment, in which people are repeatedly exposed to signals that remind them of past traumas. What is lesser known is that in 1924, Pavlov made another huge discovery by accident. Apparently, the thaw in St. Petersburg during the spring caused the river Neva to flood his basement laboratory, inundating the dogs, his experimental dogs, and they were trapped in their cages with the waters rising, and there was no way for them to escape. So the dogs survived, but after the water receded, they continued to be terrified even though they were not physically injured. A significant portion broke down, they emotionally, behaviorally, and physiologically. Many laid around motionless, barely paying attention to what was going on around them. Pavlov interpreted this as a sign of ongoing terror, which had obliterated any curiosity of their surroundings. So we now know that physical immobility and loss of curiosity are also typical of frightened, traumatized children. And some of these dogs sat shaking in the corners of their cages, while others previously tame would strike out viciously at their handlers. And we know this is kind of, again, behaviors well known today in children who have experienced trauma. So Pavlov did show that after exposure to extreme stress, animals find a new internal equilibrium different from their previous organizations. The dogs kept acting like they were in grave danger long after the event. And he even measured their physiology and found both markedly increased and depressed heart rates in response to minor stresses. So that was a sign of instability of the autonomic nervous system, as well as like full-blown startle reactions in response to slight changes in their environment, like approaching lab assistants. And honestly, when I was in the course with Kelly Mahler and Amy Lynch, as they're explaining interoception, I couldn't help but think about the people in my life and how their interoceptive systems work. And my pets, of course. I don't have children, so my pets are my children. And I have one dog who, he's always been a little bit anxious, but when he was about 7, I was taking him to walk him, and he was attacked by this pit bull that just came running out of the park. And I immediately picked that dog up because I know my dog would snarl, and I didn't want my dog to kind of initiate anything. So I picked my dog up, and I had my other dog down there who wouldn't hurt a fly and doesn't initiate anything, total social dog. And that dog started jumping up at me, but he wasn't trying to attack me. He was trying to attack my dog, who was actually trying to protect me. So my dog ended up jumping out of my arms, and the pit bull attacked my dog. And so he had bitten his neck, and it was really rough shape. And I was screaming and panicking, and had to take him immediately to the vet. And, it was just a stressful situation. He, of course, ended up physically being fine after the event, but my dog has never been the same since. And I honestly think that traumatic event really did affect his nervous system. And now, I'm trying to work a lot of days of the week sitting in this new office I created in my house, and my dog won't leave me alone. He's jumping up and having little panic attacks all the time, and he needs me to come and understand him and kind of be like that insula for him, and to figure out how to help him and comfort him. And he definitely has panic attacks like this all the time. So I think this plays into like the intersection of trauma and interoception within the insula. Like almost every brain imaging study of trauma patients finds abnormal activation of the insula. I want to point out that book in the bottom corner, The Body Keeps the Score, by this author, Vander Kolk. He's a doctor and scientist. I think this book is really interesting about relaying how it's a book really about trauma, but it really goes into understanding the brain and how the body connects. So, how do we even know that we are alive? And what does consciousness and unconsciousness have to do with this? In 2004, one of his colleagues, Ruth Lanius, proposed a new question, like what happens in the brains of trauma survivors when they're not thinking about their past? And her studies were on the default state network, or the DSN, which opened up a whole new chapter in understanding how trauma affects self-awareness, specifically sensory self-awareness. So they recruited 16 normal Canadians, were recruited to, and they lied in a brain scanner and were instructed to think about nothing in particular. She asked them to focus on their breathing and to try to empty their mind as much as possible. They then repeated the experiment with 18 people who had a history of severe childhood abuse. In the normal subjects, she saw activation of the DSN regions. So you can see in the top picture of the brain where they point out the anterior cingulate, the posterior cingulate, the medial prefrontal cortex, the insula, and the orbital prefrontal cortex. All of those areas were lighting up for the normal subjects. But in the individuals who had experienced the trauma, the only area of their brain that was lighting up when they were in this experiment was the posterior cingulate. So Vander Kolk explains this area within all those different areas as like the mohawk of self-awareness. So it's like the midline structures of the brain starting right above our eyes, running through the center of the brain all the way to the back. And all of these structures are involved in our sense of self. So the largest area is that posterior cingulate, and it gives the physical sense of where we are. It's like our internal GPS, and it's strongly connected to the medial prefrontal cortex, which is kind of like a watchtower. I think of it as really helping us with judgment and perceptions of the input we are receiving. So it's helping us understand and differentiate that when we smell smoke, is that a danger, or do I need to leave my house? Is the house on fire, or is that the food that I'm cooking? So it helps you with that perception. And the insula is connected to this, relaying that information from the viscera, from our body organs to the emotional centers. So the parietal lobe integrates the sensory input. The anterior cingulate coordinates all the emotion and thinking, and all of these areas contribute to consciousness. So the conclusion they made was that, the only area that was lighting up with the individuals who had the history of trauma was that posterior cingulate. And that is the area responsible for our basic orientation in space. So maybe they were really just thinking about where their body was in that brain scanner, and the other things were not lighting up. And the conclusion they made that was in response to the trauma itself and in coping with the dread that persisted long afterward, the patients that had experienced the trauma had learned to shut down that brain area that transmits the visceral feelings and emotions. That define and accompany the terror. So yet, in everyday life, those areas are responsible for registering the entire range of emotions and sensations that form the foundation of our self-awareness and our sense of who we are. So tragic adaptation had occurred, and in an effort for these individuals, they were just trying to shut off the terrifying sensations, but they also deadened their capacity to really feel alive. So the disappearance of the medial prefrontal cortex activation could explain why so many traumatized people really lose their sense of purpose and direction. So getting into interoceptive awareness really is like a sliding scale for various body parts. And our body signals, they might be too strong, they might be too dull, or they might be distorted. For example, you may have low registration for a sense like hunger and high registration for pain. If we have a low registration for hunger, that might be adding to the obesity rates around the world. We eat because it makes us feel good. We pick things that taste good because it makes us feel good. And if we don't register that we're not hungry and we don't need to eat right now, then we may continue to eat throughout the day. And that might be a coping mechanism. I think I'm missing some notes. Okay, so body signals that are too big, that's connected to sensory modulation disorder, over-responsive. So these strong, overpowering, we might be getting too many signals noticed all at once. And then, if body signals are too small, that's more connected to sensory modulation disorder, under-responsive. Those signals are muted. We don't notice the body signals until they're really intense, like if we need to go to the bathroom, or we may not notice those signals at all. And then body signals can also be distorted, and that's related to the sensory discrimination disorder. So those body signals are noticeable, but they're not clear enough to give us that specific idea about how we're feeling. So one example of that might be like we feel like our stomach is upset, or we have, some aches or pains in our stomach, and it might be the difference between identifying if it's menstrual cramps or that your stomach is upset. So those kind of things we might not have a clear picture of. So the development of interoception really occurs throughout our human developmental process. And, talking back about, our different senses, babies are developing these senses in utero. They feel things. They have that sense of touch really early in life, and they also have the ability to hear through vibrations their mother talking to them. So the mother or primary caregivers are really instrumental in developing a child's interoception and their interoception awareness. You know, the baby coming out of the womb, they don't have great interoception awareness or the ability to regulate themselves. So they need their parents' help with this. So one thing that initiates this, it's a cyclical process. You know, the baby has a need, like they might be hungry. The baby doesn't know that they're hungry, but I mean, maybe they do, but that would be a pretty awesome baby. But, you know, the baby notices that uncomfortableness, and so the baby cries. And then the mother or close primary caregivers will figure out what the baby needs. Is my baby hungry? Is my baby tired? Is my baby uncomfortable in the position that they're in? So the primary caregivers are really acting as the insula for the infant. And when the needs are met by the caregiver, you know, the baby cries, the mother fulfills the need by giving the child milk, then, you know, the uncomfortableness fades because they have gotten the thing that they need, and the baby develops trust. And then that cycle happens all over again, all day, every day. So really, the insula is connected intimately with our understanding of attachment. And empathy involves, you know, the interaction between mirror neuron systems and, among other structures, the insula. So there is a huge intersection of trauma and interoception within interoceptive awareness. Most people who have experienced trauma have poor interoceptive awareness, almost as if they have lost part of their body. Their interoception shuts down. So this is there's huge examples within veterans. They've been able to do studies where they've noticed that, you know, veterans, they're in this fight or flight mode, and when they're, you know, on the front lines, and they have trained their bodies to nullify those signals because they need to keep working in these really dangerous environments. So they've been able to find that veterans with PTSD are unable to identify their heart rate. You know, they've done this by having them go into a study and just trying to have them feel and detect their heart rate and see how accurate it is. And veterans with PTSD have a really hard time doing that. Also, people with anxiety, they have you know, a hyperactive autonomic nervous system response, which can include hyperventilation with an interoceptive type threat. Childhood trauma is a social determinant of health, and individuals that go on to have eating disorders. So there is an interoception breakdown occurring. And what I want to kind of touch base on is that affective and homeostatic emotions are both considered and referred to as emotions. So happiness, sadness, frustration, those are emotions, but so is hunger, our sense of temperature, you know, our pain, our thirst, our needs to use the bathroom. So there's a breakdown in the natural system. Typically, we feel the sensations. You know, we feel that our stomach is growling, and we connect it to a body state or emotion. So I'd connect that to, oh, I'm hungry, I need to eat some food. And then that would guide us to make that connection and then urge us to act. I would go and get myself some food, and I would eat the food, and then the outcome would be that I'm no longer hungry. I'm regulating my body. So when the interoception system is properly working, the sensations alert us that our internal balance is off, and it motivates us to take action, to do something that will restore the balance and help us feel more comfortable. You know, if we're cold, we get a sweater. If we feel anxious, we seek comfort. And typically each emotion feels differently in the body. For example, you know, before speaking in public, your heart may race, your muscles may feel tense, breathing may become shallow. Some parents have given some ideas of where the breakdown can occur through some examples. So if an adult does not remind her, my teenage daughter will go an entire school day without eating a single bite of food or drinking a single drop of liquid. Our 10-year-old son had tantrums 4 to 5 times a day at a minimum. He was angry, defiant. We began feeding him every 2 hours and giving him an 8-ounce cup of water. We were stunned to realize one Saturday that we had gone an entire day without him having a single tantrum. That was the first day I felt some peace was in our home. So that's one example where, wow, that was just a pretty simple thing, but that really helped regulate that child. Not realize that I am getting angry, exploding with anger. By then it's too late. The feelings are overwhelming. I have little control. I would only realize I was angry after I kicked or hit something. I feel so many things inside my body at once. It's messy and chaotic. I can't make sense of it all. I can feel negative emotion, but I'm not able to identify which one it is and why it is happening. My son has been taught every single coping skill known to man. Take deep breaths, go for a walk, ask for help, etc. But he doesn't feel the need to use these strategies in the moment. His school labels him as a major behavior problem and sees him as oppositional because he won't use the coping strategies that we've taught him. So I think that goes into play that, you know, these kids, a lot of kids with behaviors especially, you know, they're not trying to be naughty necessarily. No, who wants to be naughty, you know, but the strategies that we're trying to teach them, they're not ready for. You know, we're oftentimes using a curriculum called the zones of regulation. And there's the blue zone, which affects, you know, if you're sad. There's the green zone, which is the happy, good, you know, I'm ready to go, ready to learn. There's the yellow state, which is frustration. And then there's the red zone, which nobody wants to be in because that's got a negative connotation. It means you're angry and frustrated and mad. So I think one thing that is a huge piece that interoception brings to that table is these kids, they don't know if they're warm or cold or hungry or what. So they're not quite ready to be able to identify those feelings of frustrated, sad, and whatnot. So trauma, interoception, and OT. Interoceptive awareness building. What is our role? Can interoception be improved? Yes. So luckily, all the psychological studies and neuroscientist studies that have come out there have really shown that that interoceptive awareness can be improved, and really it's good for anyone. So the first, and it really depends on who our clients are. So if their clients are young children or have cognitive issues and communication issues, you know, we're going to start a different place than we're going to start with children who don't have any learning disabilities, but maybe have emotional regulation difficulties. Or if it's an adult experiencing chronic pain, we might start in an even higher level. But essentially, we need to teach our clients about our senses and about the human body and how the nervous system works and how it's all connected through interoception. So like within, for example, Kelly Mahler created what's called the interoception curriculum. And the way she breaks it down is that we start learning about our body and our body sensations and identifying them. So one idea is that we start from the most external body parts, like our hands, our feet, our mouth, our eyes, ears, nose, voice. They go through and spend time on each body part and teaching the individuals how to recognize how their sensations feel. So within, starting week 1, we might be working on the hands, and we would be teaching the language that goes along with it, but teaching individuals how our hands can feel. And there's a whole long list of about 20 different ways our hands can feel. So our hands can feel hot, cold, wet, dry, fidgety, loose, tight, fisted. So she also guides us through doing focus area experiments so we can target teaching how each way our hands feel. So one thing that she might tell us to do is, okay, squeeze your hands in a fist really tight. Squeeze, 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 squeeze. And then you would ask the individual to connect that with how do your hands feel. And you can tailor it down to if there are cognitive or communication difficulties. So what I'm doing right now with some individuals with those difficulties are just bringing out a few words and giving the opportunities for like yes, no responses. So, when you do the fist, 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 hold yourself, squeeze your hands together for 10 seconds. I might just say, do your hands feel cold or tight? And I'm just trying to target them, recognizing those basic ideas. And then, so the way it works is you go through all these different body parts, starting at the hands, feet, mouth, eyes, ears, nose, then your voice, your cheeks, your skin. Then you go on to the muscles, lungs, heart. So you're going more internal, and those are more difficult for us to kind of identify. So you kind of get into the head, stomach, bladder, and whole body. And I actually talked to an occupational therapist when I was at this conference learning about it. And she said she's used the curriculum with, a high schooler who was still having toileting issues at school, and, just teaching him how the bladder feels with full or empty was really huge, and just getting him to be aware of and creating a schedule to go to the bathroom on a regular basis. Let's see. It's also really important to tie in teaching interoception into daily activities. So with the kids that I'm working with, once they come in from recess, I'm having the paraeducators and teachers ask them through what Kelly calls it as like a body check chart. So once we teach this language to the children or individuals, it can be adults too, where they have that language. So then we do a top-down scan, and we ask them how their body parts feel. So, if you've only done a few different body parts, you just start with the ones that they've been familiar with. How do your hands feel? How do your feet feel? How does your mouth feel? And then once they are able to identify at least a few of those, they may be able to connect it to an emotion, but that's really the second step in the curriculum, is to connect it to the emotion. But what I saw working with kids last year in a classroom with kids with autism, where they were implementing this curriculum through my guidance as a precursor to the zones of regulation, I had one student who was a 3rd grader. I like to think of him as like a young Alex Trebek, because he's coming in doing echolalia with a lot of Jeopardy things, which definitely could be worse. So I like that he's just the little Alex Trebek of the class. But, an example for him was he came in from recess, and the paraeducator said, Matt, how do your hands feel? And he said, my hands feel cold. And she said, how do your feet feel? And he said, my feet feel sweaty. And then he just like interrupted her, and he just goes, Teacher Sarah, I'm in the green zone. Okay, I'm fine. So I thought that was really impressive, that even only after, using this curriculum for a few months, he was already connecting it to, I get it, I'm in the green zone, leave me alone. And I was really impressed that that was already developing. So I just want to touch base, like I said earlier, self-regulation is connected to both our affective and homeostatic emotions. So these are our affective emotions: happiness, anxiety, frustration, boredom, distraction, focus, irritation, embarrassment, excitement. You can read the list from there. But then self-regulation also comes into play with homeostatic emotions: hunger, thirst, fullness, need for the bathroom. So these are all considered emotions. They're just lumped under different categories. So interoception and self-regulation. Self-regulation in general is just the ability to identify and manage the way we feel. It's connected to homeostasis. What is homeostasis? It's that ongoing process that maintains the health, comfort, and well-being of our body. And it happens through changes in tissues of our body system and our body alerting the brain via our interoceptive system. So consciously, we feel a sensation and are behaviorally motivated. Balance. This use is self-regulation. And then unconsciously, the automatic messages sent from our brain to regulate the body. And together, the conscious and unconscious are similar to an iceberg. So 80% of all that input is unconscious, and only 20% is the conscious things that we can observe and feel, like our heartbeat. So overall, we have the body signal or emotion, like heavy eyes, slow muscle, unfocused brain. Then we connect that to an emotion of tired, and that's why I have that cat yawning in the screen. So what is the action? If we're feeling tired and it's not time for us to take a sleep, what can we do? We can drink some cold water, we can take a walk, maybe have some caffeine, do some self-talk. But you have to know exactly how you feel in order to manage it effectively. So noticing the sensation is the first step in noticing how the body is doing, and then we connect the sensation to an emotion. So we might notice the sensations like faster heart, clenched fist, tight muscles, louder voice, and then we connect the sensations to a meaning: angry. So those top two bars, notice and connect, that is interoceptive awareness. And hopefully, if our interoception system is working, it gives us the urge to act by doing something that's regulating. So, go for a walk. That's the action that's going to regulate us. And then the outcome, hopefully, is that discomfort fades. No more fast heartbeat, clenched fists, tight muscles, louder voice. We're no longer hot. So hopefully, we're able to in tune regulate. And I also wanted to bring up pain. I think addressing interoception is essential when helping clients manage pain. Teaching clients about interoception is a really good starting point. Every body part has different ways it can feel, and people who have chronic pain may really be having a really heightened state of their interoceptive system. I think, like I said, people and animals in my life have really brought me into thinking about interoception, and my close family member actually has a chronic pain condition right now. And I went to I think it's called the Oregon Pain Summit, but it was that conference in January. And as I was going to that conference and learning more about pain, I'm a peds therapist. Pain isn't really necessarily my thing, but since I have a family member who is experiencing chronic pain, it's hitting really home for me. And I can't, expect to be that person's personal therapist, but I also can't help but look at the science and trying to think what does this family member need? And I think really if occupational therapists use the interoception approach within pain management, I think that would be a really great starting place. I actually had a paraeducator, the paraeducator that was implementing this the most in the schools. She actually had a really significant issue where a child threw a chair at her, and she has pain issues at baseline. So she had an injury to her leg, and it affected it, of course, like the chair ended up affecting her nervous system within her leg. So as she was going through physical therapy, I was actually teaching her more about interoception to help the children we were working with. But, we couldn't help but link it to her pain. And she even brought in the page, there's all these visuals that we've created. And when she was teaching the kids about how their feet feel, she brought that visual into the physical therapists and went through all these little exercises that the interoception curriculum has and things that you can do with your feet. So, providing different sensory stimulation and seeing how the body reacts and seeing how her pain level can amplify or decrease or whatnot. So if you're interested in exploring this more with patients who are experiencing pain, I really would encourage you to read the article Ghosts in the Machine, Interoceptive Modeling in Chronic Pain. It's a really interesting article that just came out, I think, last year, and it really shows the huge way that we can work with interoception to help chronic pain. So building interoceptive awareness can enhance treatment approaches. So all of these things, zones of regulation and, the face's pain rating scale, they're both, we're noticing sensations and giving meaning to them. And that's what the interoception curriculum does too. And I'm not connected to Kelly Mahler at all. I'm just really inspired by her. So I'm not getting any financial benefit by telling you about her curriculum or about zones of regulation. But those are definitely treatment strategies that are already using this interoceptive approach. And the zones of regulation, it wasn't necessarily developed with interoception in mind, but it really is that next step. And I think the interoception curriculum by Kelly Mahler is a really good precursor to the zones of regulation. But it also goes along with the pain scale too, and how we notice sensations and we give meaning to them. So really, interoception is a mindfulness strategy. Mindfulness is the quality or state of being conscious or aware of something. It is a mental state achieved by focusing one's awareness on the present moment while calmly acknowledging and accepting one's feelings, thoughts, and bodily sensation, used as a therapeutic technique. Like yoga is a huge mindfulness strategy that's evidence-based. So mindfulness is based in evidence, and it will help our clients be more connected to themselves and build better interoceptive awareness. And everyone can benefit from these strategies. So, there are various OT settings, and interoception, I think, can play a huge role in all of these different settings. Mental health, prisons, ECSC, state hospital, community mental health settings. I know I don't have them all in here, but it really can play a huge role. And then I was going to share with you a clip from this film, which is on Netflix, but I don't want to take your time up by doing that. I think since we're coming down to the next 14 minutes, I think it might be better served if we had a little discussion. But this video, The Beginning of Life, is on Netflix, and it really talks even about the neural connections that are happening with human development. And I think, even if you're not a peds therapist, I think it's really helpful to go and watch this film and think about, like, what are the experiences that babies are experiencing when they're developing, and how does our insula develop during early childhood, and what's firing in that baby's brain. So going back to the slide that has the circle where we're saying, the baby has a need, the need is met by the baby cries, the need is met by the caregiver, and then the cycle continues where the baby's already regulated. And also, you know, thinking about that too, volition ties in hugely with interoception. So a child's drive to engage in occupations is the mechanism through which they will develop skills and competencies. And, you know, they also talk about, you know, children through development, they do things over and over and over again. And the repetition is creating those pathways, and they're problem solving. And it's really developing their skills, not only with fine motor skills, but social emotional and self-regulation skills as well. So we are kind of to the discussion part. And if you guys could, if anybody's interested in participating in a discussion, you're welcome to turn your cameras back on. If you guys feel comfortable, I'd really like to hear like what your thoughts are about this, and just give me like an introduction of yourself and maybe what area of occupational therapy you practice in. And then I'll call out other people too.
I guess I can get started. Thank you so much, Katie, for doing this presentation. First on, behalf of OTAO as well for the conference. But I also wanted to mention that, I have worked in skilled nursing facility for a little while, and then I have been working now in early childhood specialized education. And so this information has been relative in both settings. So I feel like this has been really interesting to see how it can be applied across settings.
Awesome, I appreciate that. Yeah, I guess, Kaylee, it looks like your mic is off. Would you mind going?
Yeah, I was gonna just comment, it was really interesting. I like all the research pieces that you added into, because sometimes you get the families who really want that, and other times they're like, I don't really care, just tell me what to do. I've worked in outpatient peds, pretty big variety of kiddos the last 2 years, but now I'm transitioning to early childhood with Jasmine.
Awesome.
So it's all peds, but so often, and I wanted to get your thoughts on this, a lot of kiddos, especially ones with the sensory processing challenges, have a lot of struggle with that interoception, specifically bladder, maybe temperature, like they're wearing t-shirts and it's 30 degrees outside, or wearing long sleeve shirts and it's 90 outside. And so temperature, bowel, bladder, sometimes that hunger. So that's a really broad kind of statement comment, but other than that, going through that kind of interoception program by Kelly, is there any other specific things that you've done to target, especially for some younger kids, like 3-4-year-olds, who maybe that cognitive piece isn't fully developed?
Yeah, I think that's where, I think Kelly's the one that's really done the most connection, giving us therapy tools. So I think, if you do want to dive into this, I would really recommend taking her class. But yeah, like I understand where you're coming from. And I think that 3- and 4-year-olds can definitely benefit. And I think a lot of it is just tailoring down that curriculum and, offering, kind of tailoring it down, even communication wise, and saying yes or no. And she does guide us through that, so we can limit those choices for what the target areas we're trying to get them to identify, and then to be able to, give them strategies on treatment. But yeah, right now, like I'm trying to develop online curriculums for these kids in the schools, and it's not like I have interoception goals in the school district. I just came across this and I feel like it's so relevant. And I actually have like 7 schools that have behavior classrooms in them. And I'm just trying to connect with those teachers and paraeducators and trying to teach them how to implement this curriculum with my guidance so that the kids can benefit, because I just know there's kids out there right now just they could use this.
Yeah, and like you said, given the the trying year that everybody has had, so it's like some of these kids who are already struggling, it's been even that much harder. So
yeah, exactly. Like I'm just trying to come meet kids where they're at. It's like, who cares about fine motor right now? Yeah, that's going to be really important. But I think the biggest thing right now is to just be that grounding person in these kids' life and come from a trauma-informed care approach and to really think about them holistically.
Yeah. Okay, that was helpful.
Does anybody from a non-peds arena want to chime in about what their thoughts are? And I'm kind of leaving it wide open.
I can jump in. This is Sean, and my background's all pretty much mental health, on all ages, but primarily teens through adulthood. And the thing that struck me kind of through the whole presentation, I just kept thinking about how what we're doing right now, in fact, is affecting interoception. The fact that the world has gone virtual, where physical contact is out the window, and everything's flat on a flat screen now. And what kind of impact is that happening for all populations? I mean, I'm particularly thinking about mental health populations because I'm supervising a level 1 fieldwork student or level 2 fieldwork student right now at a mental health site, and thinking about some of the folks we're seeing and just how isolated everyone is. And so what kind of impact does that have?
Yeah, we're definitely experiencing some sensory deprivation. I mean, I'm noticing that even just in my little cubicle workspace here. I know I've created a standing desk so that I can have opportunities for movement, and I'm getting tight hamstrings from sitting still all the time. And so, yeah, I think that that's definitely something to consider with our families and the individuals we work with. Like, they're all sitting at home too, even with our older clients. A lot of us work with older adults, and they can't get out and do things as much either, or they're nervous they might get COVID. So there's a lot of individuals around the world, both with and without disabilities, that are affected.
I wonder what the long-term implications of this are going to be once we finally do get to open back up.
Yeah, definitely. Does anybody else have any input or come from a different setting?
I sort of spanned both of them. I used to teach elementary school and saw some of these types of things, in the kids in the lower elementary school that I taught. But now I'm working with the other end of the spectrum in home health with adults, older adults usually. And the pain issue kind of hit me as something I deal with, because a lot of the people that we work with have pain, either chronic or acute from a recent surgery. But sometimes it's strange when they identify. We always have to ask them, how much pain are you feeling? Where is the pain? And some people will say, oh, it's a 9 out of 10 pain. And yet, they get up and show me how they get to the bathroom and into the tub and out of the shower. And I'm like, that's not 9 out of 10 pain, but yeah, it's 9 out of 10 pain. It's really bad. So they're not maybe being in touch with the pain that they're having.
Yeah, and I think that really is huge. I mean, the family member that I was mentioning earlier that has complex regional pain syndrome, they actually have a history of having ADHD and sensory problems as a child. So I think, maybe they didn't have a lot of trauma in their life, but maybe they had a poor interoceptive system to begin with. And now that individual in my family is doing the exact same thing, where they're rating their pain as a 6 or 7 all the time. And I'm like, I'm sitting, nice, enjoying our dinner with you, and you're not exhibiting any pain signals to me. So, and I'm an occupational therapist, so I want to understand you and reach out, meet you in the middle. But yeah, it's confusing to me too. So I think that's where interoception, there is some kind of breakdown going on. So hopefully you guys can spread the word, and when I have a family member that has interoceptive difficulties, I can send them to more therapists who know more about it, and we can kind of use that to help each other. I guess we're coming down to 3 more minutes. Does anybody who hasn't talked have any questions or anything?
I had a quick question. What was the name of that Symbia or something? I couldn't quite write it down.
Alexithymia.
Symbia? Is it?
It's
How do you spell it?
here. I'll put it in the chat.
Oh, maybe that's good. Yeah. I tried to Google it and I couldn't spell it. I must have misspelled it somehow.
Yeah. So if you Google things, yeah, alexithymia is pretty much just that terminology of like poor interoceptive awareness.
Katie, there was also a question a little further up in the chat about the link or resource to the specific curriculum that you mentioned for Kelly Mahler.
Yeah, we'll put that here too.
Thank you.
So you can go to her website, kelly-mahler.com, and she actually has a lot of links to different interoception research studies, and there's webinars that are linked to there and podcasts where people have talked about interoception more. And yeah, I ended up purchasing like everything she has. So I'm just like running with it and trying to create virtual classrooms and things with her kind of ideas in mind. But if anybody wants to jump on board with this, like Kaylee or is it Jasmine, either one of you guys, I'm trying to like wrap my head around how to get this out. If anybody else has any more questions, you can feel free to reach out to me. I'll put my email in the chat too, so you can always connect with me.
Well, yeah, thank you so much.
Sorry. I'm just like so eager about this subject, and I really appreciate you guys coming here today. You know I bug my boyfriend all the time because I talk about interoception all day and night, and he's like, yeah, I know. So, you know, it's just like I'm connecting it with the world around me, and oh, my dog has poor interoception. Like, so, you know, I appreciate you guys being here today, and I know I'm over enthusiastic about it, and it might not have come off when I was just talking to the screen at you as I'm trying to read my notes, but it is an area that I'm really excited about.
Well, we really appreciate your time, Katie, and I personally found this information extremely valuable. So thank you so much for presenting at this year's virtual conference. It's definitely a new platform for many people, but for all the attendees, you'll see that in the chat I put in the link for the course survey, and there is a case-specific password to use when you fill out the survey. So please do make sure to copy and paste that to fill out the survey and receive your course certificate for later and keep for your records. If you do have any questions or concerns, do feel free to reach out to us at info@otao.com, and then make sure you copy Katie's email for later if you want to reach out to her, and that information will also be available to you on the recorded course link that will be sent out later on today. So,
and just a side note, I have created an occupational therapy assessment tool called I renamed it as the visualactivitysort. And I'm not trying to plug this in for you guys to necessarily go out and purchase anything or anything, but if you're interested, you can go to that website, visualactivitysort.com, or reach out to me. I'm just trying to look for more feedback. So if any of you are interested, it's similar to the activity card sort, where it's a lot of different cards of different occupations, and you can sort them in different ways. So if you're interested, please reach out to me about that too.
And Katie did also donate that to our silent auction, so if you would like one, you can put a bid on that.
Thank you. I really appreciate you guys all being here today. It looks like our time is up, so I will